Hello, everyone, and welcome to this evening's webinar, Evolutions in Hepatocellular Carcinoma in the Era of COVID-19. My name is Jeff Prescott, Senior Vice President, Clinical Communications with MJH Life Sciences, the parent company of OncLive, and I am your host and moderator for tonight's program. The format of today's program is a collaborative discussion with an expert panel. I'll be guiding them through several areas of discussion, including COVID-19 infection risks for patients with HCC, the impact that COVID has on care of patients, including diagnosis and treatment options such as transplant, surgery, liver-directed therapy, and other systemic treatments, and ways that they've been adapting their practice as well as research in this unprecedented times. We'll be talking with our panel for about 40 minutes, and then we'll have some time for questions. You can submit questions to the panel using the On24 control panel. So you'll see on the bottom of your window a number of options for you to click. Some of those will have the slides, some of those speakers, Q&A. Click that and you can enter your questions there. If you need help, you can also be able to direct questions to that. And our folks on the line can be able to help you if you're having difficulties hearing or seeing the presentation. Also, this event is being recorded, and a link will be shared with everyone that registered. So for all our attendees, if you want to rewatch any portions, you certainly may. One more thing before we start, I'd like to acknowledge tonight's sponsor, Genentech. We thank them for their support. I'd like to note that information and opinions shared here are that of OncLive and our faculty panel. So speaking of faculty, let's get started and meet tonight's panel. So I'm going to ask our faculty to introduce themselves. We'll start with Dr. Finn.
Hi there, everybody. Dr. Richard Finn from the Geffen School of Medicine at UCLA here in Los Angeles. I'm a medical oncologist.
Super. Dr. Kim.
Good evening. My name is Kevin Kim. I'm the professor of the radiology and the medicine in the medical oncology at the Yale School of Medicine. I lead the interventional radiology and the interventional oncology program here at Yale.
Super. Thank you. Dr. Morse.
Hi, I'm Mike Morse from Duke University Medical Center, and I'm a medical oncologist with an interest in GI oncology and hepatocellular carcinoma.
Fantastic. Thank you. Dr. Salgia.
Good evening, everyone. I'm Marina Salgia. I'm a transplant hepatologist at Henry Ford Hospital in Detroit, and my focus is in hepatocellular carcinoma. Thanks for joining.
Thank you. So a couple of things as we start. Today's statistics, I mean, none of these numbers are good, but I just want to make sure we highlight where we're at. So right now, globally, we have about 3.6 million cases. In the U.S., we're about a little over 1.2, and with about 71,000 patients that have passed. Many of our states are starting to open up a bit. Social distancing is still a thing. Probably will be for a while, but I think we're certainly seeing some variation on the themes there. So our panel, we have them from all across the country. I'd like to start out and just ask you. And Dr. Salgia, since we ended with you, I'll ask you to start. What's it like in general in your area, and what's the temperature like with respect to COVID-19?
Sure. Yeah, thanks, Jeff. So, we kind of unfortunately in Detroit have gotten our notoriety for not the best of reasons, but most recently in March, we started with 2 cases and pretty quickly exploded in terms of the number of cases in Detroit. It's mostly affected the southeast part of the state, pretty much focused around the city itself. And we saw at the beginning that the hospitals in the city were pretty overwhelmed with COVID-19 cases, and slowly, we are starting to see a decrease in number of admissions and more intensive care unit available beds with fewer and fewer patients on the ventilator. So I think we're overall seeing some initial cautious signs of optimism and improvement, but it has certainly changed the care that we deliver, and I know we'll be going through that tonight.
Super, thank you. Dr. Morse, so we'll move over to the southeast. What's it like in North Carolina right now?
Yeah, we had the advantage of seeing what was starting to happen in other parts of the country, and the leadership started preparing earlier than the upsurge occurred. So at the current time, and I'm just looking at our dashboard that we're provided every day, we have 59 patients in what's probably about close to a 1,000-bed hospital who were admitted with COVID-19. We've had 43 deaths. But I think an interesting statistic is that throughout this whole period of time, the number of tests positive of the total number of tests has stayed pretty steady at about 6%. So we're certainly testing a lot of patients, and not just because they're suspected of having COVID-19, but if people are going to have procedures, for example. So there's a very high test rate. Fortunately, the positivity rate has been relatively low, and it's sort of mirrored what's happened across our state.
Okay. We'll move down the coast, or I should say up the coast. Dr. Kim, what's Connecticut like right now?
Yeah, so as you know, Connecticut, the state is next to New York State, so we were hit pretty heavily. I have to say, however, our first patient came to our hospital on March 13th, so we were few weeks behind New York City, which allowed us to prepare and did a lot of investment, a lot of work to prepare for. So in the state of Connecticut, I believe that we now have almost 30,000 confirmed cases. Our hospital, Yale New Haven Health, just last week discharged 1,500th patient as the treated and healthy after admission for COVID-19. So we still have a pretty high number of patients in our system, but it's steadily, slowly going down. But also our ICU and the vent are heavily utilized by our patients with the COVID-19.
Okay. And Dr. Finn?
Yeah, so California is interesting. You know, we have a population of 40 million people, which is probably more than all three states we've heard about combined. And we locked down pretty early. You know, I think the leadership here looked at Milan and got very nervous, especially because of our proximity to Asia, right? We have a very diverse community. Also Seattle, right? Seattle was the first nexus of cases here in the United States. And, you know, things started slowing down very quickly here. And I think it has spared us because of that. And when I say spared us, looking at the dashboard here in California, for 40 million people, there's been about 55,000 cases and 2,200 deaths across the state. And about, I think, 1,500 of those deaths occurred in LA County alone. And LA County is about 10 million people. And part of it, I think, is our early lockdown that has mitigated a surge that we were anticipating and I don't think really arrived. It's been kind of a steady stream. Obviously, there's an increase in cases as things are being tested, but the concern about, you know, a surge on the ERs, on admissions, that has not really materialized. And it's also, I think, somewhat of the California lifestyle, right? We're not a very dense, like LA is a lot of people, but we don't use public transportation so much. And people are in their cars a lot. We're not on top of each other as much. And a little more natural social distancing, I think, has spared us. So certainly it's had a big impact on every aspect of our lives. So I think relative to New York, we've done better.
Okay. Certainly, you know, New York, unfortunately, is leading it in the Northeast. So I'm located in New Jersey, and though not close to New York, it's still a significant concern here in the Philadelphia area. So let's start talking about some of the patients specifically with HCC. You know, throughout what is your greatest concern for these patients? Are they at increased risk for infection? Are they, you know, what's your concern like for the population overall? We'll say,
I would I would say, from what we understand about COVID, I mean, most patients do very well with the infection. That's a fact. But the patients who get into trouble have other problems, right? And I think certainly when you're talking about a population of liver cancer, they qualify as having those other problems, not only their malignancy, but also their underlying liver disease. And there can be a very heterogeneous group. I think certainly I would consider them, I don't know if increased risk for infection as much as increased risk for a complication if they get infected. Maybe they are at increased risk for getting it if they're in contact, but I think if they got it, it would be a group that would be at a higher risk of a poorer outcome.
Okay. Those additional risks, are they the ones that we've heard about? Is it risk of pneumonia? What do we know about the impact of COVID on liver function, and does that tie in with your concerns?
Yes, for sure, and maybe our hepatologist can weigh in on that. I know EASL and other liver societies have issued some guidance about managing patients with chronic liver disease in this given COVID, and certainly some of the medications that might be used to manage the disease. COVID itself, I think, can cause liver enzyme abnormalities, and especially in the background of cirrhosis, that could be concerning.
Okay.
Yeah.
Dr. Salgia?
No, I was going to just add to what Rich said. I absolutely agree that, I think many of our patients with chronic liver disease carry other comorbidities as well, especially our cirrhotic patients or those with viral hepatitis. And, I think what we at least are gaining knowledge about with COVID-19 is that some of those specific comorbidities, whether it's obesity or diabetes or others, are the ones that tend to put our patients at higher risk of potentially getting more ill from the standpoint of the respiratory failure as well. So I think that's definitely a concern.
Okay. All right. So how is, for patients that are being, we're thinking about the treatment paradigm for patients with liver cancer, coming in is, I know obviously some of our medical services access to care is changing. How is that affecting your ability to diagnose or, begin the process to support patients with liver cancer or potential liver cancer? Dr. Morris, can you start us out there?
Yeah. Well, we're at our center, many patients, of course, are being followed by hepatologists, but there are certainly people that have symptoms that warrant further evaluation by their primary care physician. I think at the point where we're seeing people, we have to decide on should somebody have a biopsy, which is a whole discussion in and of itself. But in the COVID situation, it's a little bit more challenging to arrange something that would be considered elective, like a biopsy. The imaging, there's been somewhat of a slowdown in radiology, not too bad, but trying to get standard imaging for patients. The standard laboratory tests, I think would be easy to get, and although they are, we have, our center has many sites where people can go get labs done, but those, people are still trying to stay at home and not come in, so even just getting the basic workup of labs, it can take a little bit longer for people. So I just find it's a little bit more frustrating trying to get the wheels moving than we were used to in the past.
Is it, are the wheels moving? Obviously, we talked about some of the access issues. Is there more from a patient perspective that they're fearful to come into a hospital? Or is it literally that this is not considered a necessary or emergency procedures or diagnostics to get them in the system?
Yeah, we find that generally the concern is that people with hepatocellular carcinoma can have a disease that can proceed quickly. Their underlying liver disease can decompensate quickly. So I wouldn't say it's in the same category as some other malignancies where an extra month or two. I take care of patients with neuroendocrine tumors, for example, and that can certainly wait. But hepatocellular doesn't. But it is emanating both from patients and the system itself. Some people will come in to get extra testing, and they're reluctant to come in to have discussions. We're going to talk about telehealth more later, but there's some situations where people just are delaying coming in. As far as the system itself, certainly a slowdown on procedures to some extent is when I talk about the wheels moving just a little bit slower than they had before.
Okay. Have any of your health systems, and as for anyone, set up specific procedures or protocols to be able to, at this point, get the wheels moving a little bit faster?
What we had to do, Jeff, is basically from the start decide what are considered time-sensitive procedures, as well as from imaging standpoint, biopsies included, and basically had to do that by disease state. And as time goes on and we're further into this, there's a little bit of loosening of the reins of what we would consider to be time-sensitive and who we need to prioritize. So I think, to answer kind of what you asked about the fears, I think there's a combination of fear from the patient, at least the last 6-7 weeks, that has changed access and availability of getting in for procedures, and how often screening is being done, followed by diagnostic tests. And then that combined with just having to determine which patients we need to prioritize has influenced it. So we came up with a protocol for that, and slowly are adjusting so that we can accommodate more and more patients.
Okay, and starting to think about that in the treatment modalities, and there a few areas that we'd like to talk about. The first one from a surgical standpoint, again, I'll toss this out. In terms of managing surgeries, is there the protocol for prioritizing or identifying which patients you may want to delay, for another 30, 60 days? Hopefully we're getting a little further out. Is there any standard or best practice on what you've been using?
Well, maybe I can start here. So I have to say that to answer for the previous questions, even in our state of Connecticut, which has been heavily affected, even during the crisis, cancer patients were a little bit different. Elective cases, elective procedures, elective surgery. Those were deferred in most of the healthcare systems. But when it came to cancer patients, both on the diagnostic side as well as the therapeutic side, we were trying to take care of the patients, both from interventional diagnostic as well as the therapeutic side. So now in the state of Connecticut, we are in the sort of a flattened curve. So we are trying to reopen. We are trying to re-engage into the normalcy of the slowly into the care delivery. So we are opening up further. Now, when it comes to HCC or the liver cancer specifically, what we have used in our lab in interventional had been that even though elective cases we did defer, but the cancer patients, particularly HCC patients, we did the personalized where if the care, whether it's a biopsy, whether it's the therapeutic care for the HCC or the cancer, were to be deferred 30 to 60 days, and whether or not that would affect the outcome of the patient and or harm the patient. And if the answer is that it would, then we would take care of them even during the time of crisis, as well as post-crisis. Of course, if that is not the case, as in, let's say, Dr. Morse spoke of the neuroendocrine tumor or the carcinoid patients, those patients might potentially be deferred. But as the as it was mentioned earlier, there's a lot of actually patients' perspective as well. What we found was that even though there was a recommendation by the tumor board as well as the individual practitioners, some of the patients had some concerns and hesitation of going through the workup and or the therapeutic procedures. So obviously the patient has been part of the treatment planning, the decision making.
Yeah, certainly. What's been the reaction of some of your patients if you're having to delay either by choice or prioritizing? How are they dealing with that type of conversation?
Right. So each individual physicians as well as individual the departments might have done things differently, but I think that all of us agree that the patient needs to be well informed and benefit and the potential risk of the discussion needs to be had with each of the patients at a personalized level. Now, once we did that, on some patients that we would recommend deferring, for whatever the reason it may be. It could be because of a liver status, tumor burden, and or the patient's comorbidities, right, as well as the patient's performance status and so on. I have to say that some of the patients actually found that to be glad. The patients were pleased with and were glad that the doctors are recommending that such deferment would be recommended, as versus actually some of the patients would be actually quite unhappy and or actually quite keen on the further cancer treatments. I have to say that if the latter were the case, we would deliver the care for the patient, but obviously we would always have the patients as a part of the decision making on the treatment.
Okay. Well, along those lines, have anyone had to defer surgery and perhaps use another type of treatment modality in its place? I mean, that's obviously part of the conversation with the patient, and a lot of variability there, but is that something you've seen as an option? Again, something for other practitioners to think about if they're coming up to such scenarios.
I think
we've had to do that. Go ahead.
No, I was just going to say,
go ahead.
Patients who are borderline, right, maybe resectable, we'll take a look. Those patients, I think we've backed off on a little bit, right? We're not taking the ones that are at high risk for complication or just going to come in, get an XLAP and say, this patient is not resectable. The only patients who I've seen resected are the ones that are clearly resectable, slam dunk, low risk patients. Otherwise, I think there is probably a little more bias to do something local regional up front.
Okay. Dr. Salge, do you want to add to that?
No, I agree. We've had to hold off on resection for the past about 7 weeks with the hopes of hopefully resuming soon, just because of lack of consistent OR availability. And so we've certainly been shifting more towards local regional, a little bit more RT, or even TARE, with the hopes of then down the line still proceeding with resection for those patients. So not necessarily changing modality definitively, but more rarely kind of as a bridge.
Okay. So the question, and again,
I was going to say transplant has slowed down significantly, I think, nationally, because of concerns about COVID.
Mm-hmm.
Okay.
Yeah.
Well, good. That's actually next on my list, so I'm glad we can start that. I mean, it's slow down. Is that have you any criteria been adjusted? Is it still, you said slow down? Is it still occurring? Is there, what's the environment like for a patient who's looking to get a transplant?
Well, as you know, transplants are given out based on the MELD score, right? And there's always many patients who don't have cancer, who have a high MELD score, and I suspect those are the patients that are being done versus the ones who have been waiting for 2 years for a transplant. Their MELD score is 32, but it's not urgent, right? They still have time. I don't know in Detroit.
Yeah, so absolutely. We had to come up with criteria, whether there's an exact MELD cutoff that, we're not aware of one, but at the same time, generally the very high sickest patients are the ones where we've given strongest consideration. It's such a resource intense operation that for many reasons, whether it's availability of blood products, of course, the postoperative care, there were so many things that had to align. So temporarily it was put on hold. We have resumed doing transplants now, but are quite selective. So for example, the patient who's been downstage for HCC, who seems like they've already had a fairly long waiting time on the list, that might be a patient that we're considering, or the high MELD individual, but certainly are holding off on the lower MELD score patients, those who have successfully had some downstaging with, have successfully had local regional therapy and are in complete remission, or living donor liver transplants, where we've held off on those cases for right now. So that's kind of the environment in terms of transplant here, although hopefully slowly we'll be ramping up again soon. But patients, interestingly, even some of those who you'd think, we're very eager to get on the transplant list and carry high MELD scores, if they're at home and pretty stable, they're pretty content holding off on the operation themselves. Most of them don't want to come right now. And I think as we start to do more transplants again, hopefully that in and of itself will reinforce the behavior that things are kind of getting back to cautious optimism and we can resume.
Okay. So,
similar to Detroit, I'm in the East Coast. So East Coast, the availabilities have always been the less than some other parts of the country. So we've been actually doing a lot of bridging therapies, downstaging local regional therapies, whether it's ablation, TACE, or Y90 radioembolization. Now we continue such, especially with what we just heard of transplant status during the COVID-19 time, as well as bridging and the downstaging to surgical therapies, the soon to come in few months. Yes.
Okay. So are there, with respect to surgeries and transplants, obviously there are events that happen at specific points in time. And as we start to come out of COVID, do any of your systems or organizations have plans? Is there going to be a glut? Is there going to be a great demand in 30 or 60 days? Knock on wood, when we start to see the ability to see more patients.
Yeah, we're already seeing this issue. Back when there were predictions about the surge, many patients, new patient referrals, and so on, were already put on for the beginning of May. And so my clinic this week, for example, is already ballooned. And of course, that's going to just mean all the procedures that we send people for is going to balloon as well. So I think I'm already hearing about, how OR utilization, the IR, how they're really going to try to figure out the time slots. And at the same time, they're still talking about how to try to expand the number of hours so that not so many people are coming in at the same time, whether it's for procedures or just visits, family members, caretakers. People want to come with patients. All of those, the idea is to try to spread that out, and yet they all want to come at the same time. It's already been an interesting time.
Okay. Dr. Finn, what's your experience like in LA?
Yeah, so I think there is a concern that there will be a surge in resources utilization, right? Not from as COVID dies down, but for standard care, for all the people who have put off their regular imaging, their staging studies, their HCC screening. There's little doubt in my mind that we will start finding more HCCs in the next several weeks as we start screening people again. Hopefully they're early HCCs. There's no doubt that some patients are going to fall through the cracks. Patients who say they're going to put off their scans, and then it just never gets done. And that's probably the same for mammography and colonoscopy and other screening studies. And also at the same time, while there's going to be a need to do cancer-related surgeries, there's also all these other surgeries that have been put off as elective, right? The hernias, and things like that. So I think the system is starting to open up here, but in a very careful way and prioritizing, I think, based on those that are felt to be more medically necessary. But I know radiology is very concerned that there will be a large surge on demand for imaging.
Okay. All right. For patients who have gone through and had a transplant, either actively post-transplant or just had one, are there any concerns about monitoring them for rejection or, monitoring their immunosuppressive therapies? Dr. Morris, why don't you start us? Any concerns from you?
Well, I have the good fortune to be able to bounce this to our hepatologist. Nonetheless, I think monitoring in general with our drugs that can activate the immune system is challenging because, sometimes it can be a little difficult to tell what's a symptom from a therapy from the underlying disease. And now we're adding COVID as another factor. How do you know when a symptom is COVID-related versus your therapy? So I find that very challenging.
Okay. Dr. Finn, any additional thoughts on that?
Yeah, I think in general, we have a transplant hepatologist who will address the rejection issues. I think in general for those liver cancer patients that I follow post-transplant, right? So these are patients who had tumor on their explant and maybe we image them every 6 months looking for recurrence, or there is a small group of patients who recur after transplant and with liver cancer. And to be honest, I'm not a big fan of telemedicine, being an internist. I think we do need to see patients and examine patients, but of those that I think are high priority for telemedicine visits are those post-transplant patients because they clearly are significantly immunocompromised, and obviously keeping them at home or delaying things as much as possible until this dies down is appropriate.
Okay. And we'll talk a little more about telemedicine in just a bit. So we'll switch over. So we talked about some of the surgical and transplant interventions. Well, how about some of the others? And, want to get your thoughts and perspectives on we'll start with the liver-directed or localized therapies. Dr. Kim, can I start to pick your brain on that? What's changed from your mindset now on how you've been directing your treatment choices for patients during COVID?
Yeah, so we've always the practice according to the guideline, according to the consensus from the tumor board, multidisciplinary tumor board, as well as the personalized to each patient because everybody's different. Both from the performance status wise, liver status, as well as the tumor status, but especially during the time of a crisis. We have been practicing and delivering critical care, essential care for patients with HCC, but at the same time, we have been looking at the risk and potential benefit and the potential risk ratio very, very carefully. So those patients who are elderly with borderline or the decompensated liver functions, large tumor burdens, and so on, we have been incredibly careful for delivering liver-directed therapies for those borderline patients. So the ablations, the thermal ablation or the TACE, transarterial chemoembolization or radioembolization, these are all liver-directed therapies which have been a mainstay for intermediate stage for HCC. Those are still being delivered, but at the same time in a very careful manner. And I'm pretty sure that those will continue as this COVID-19 will be part of us for many, many months to come.
Okay. All right. Anything to add in terms of setting up either different protocols, different mindsets? Dr. Finn, Dr. Salgia?
I mean, we had to, temporarily do a little bit less in regards to ablation just because of the need for general anesthesia in most of those cases. Now, as anesthesia services are becoming more available again, I think we're trying to readdress that. I think just similar to talking about other protocols, there was a need to, and continues to be a need to prioritize certain patients who are at greater risk of progression. But I think on the other side is that concern that others expressed on the panel that in the next couple of months, we might see a backlog of cases if we delay too many. And certainly for those who are awaiting transplant, we're obviously careful to watch for trying to prevent higher rates of waitlist dropout and also trying to treat those patients to prevent progression.
Sure. Has anyone been moving, where there's the availability and appropriateness, moving from IV infused therapies to oral? Has that been an option to improve access, let people continue their treatments from home?
I would say from the cancer medicine side, I have not done that. I still choose what I think is the best choice for the patient. And, the clinic has made adaptations for maintaining social distancing. Patients can't bring someone with them to the clinic. And the timing of infusions and such is to try to minimize interactions, right? But I have not taken that necessarily into consideration when I'm treating somebody. Maybe that's wrong, but I think our choice in treatments is pretty careful, right? And patients should get what's best for their disease. Okay.
But if they're unable to, and depending where their location is, if they're in a rural area or far from the clinic, I mean, obviously, we have a certain access issues. Are there situations where that may be appropriate? And it's Dr. Salgia, any experience with that? Would you just wait giving the treatment, force them, or I wouldn't say force, but try and push them into getting their infusions?
Yeah. I think similar to what Dr. Finn said, I think we're still trying to really focus on emphasizing what's good care for the patient. But I really found that most of the patients, especially early on, if they have an option of oral systemic therapy, they kind of find it like a breath of fresh air right now just to have that option and not feel like they have to make a hard decision between, in our case, there's a little bit of a fear of coming to the city at this point. So they're on the west side of Michigan or northern Michigan. They want to stay where they are. And if they have an option that can be done at home, that's far preferable to them at this time. So, of course, if we're progressing on and by standards, they should have infusion-based therapy, we do try to instill that confidence in them that that's really the right step at that point. But I think many have been still hopeful to opt for as many orals for as long as possible just during this particular window of time.
Okay.
Part of that also stems from being able to have somebody accompany them. And temporarily, we really haven't been allowing many visitors. And I think for a lot of our population, they really do rely on having somebody else come with them to the visit or for the infusion, even though it's brief. I think that also impacts their decision-making to a certain level.
No, it's certainly understandable. Okay. So speaking of communicating, and Dr. Finn, you said you weren't a fan of telemedicine, but it seemed like it might be appropriate for some patients. You've been talking about that for some of the transplant. How have you, it sounds like you've had some experience with it thus far. Can you tell us a little bit more?
I mean, certainly, I think there's a lot of fear in a patient's mind about leaving the house, right? Let alone coming to a clinic. The clinic has taken extreme precautions. Everybody needs to have a mask in the building. To get into the clinic, you have to have your temperature checked. Patients can only come by themselves. Patients are called the day before to go through COVID screening questions. Have you had fever, cough, taste loss, etc. But even with all that, patients are still nervous to come in, understandably, given they're dealing with a serious illness and the patients who have poor outcomes tend to have underlying illnesses. So first of all, I'm very sensitive to a patient's request, right? I don't think I am automatically just going 100% telemedicine, far from it. We do look at our clinic schedule beforehand. You know, these patients tend to be very complicated. You know, I was on a telemedicine call and patients had their short of breath, right? And it's a little hard to react to that over a video camera. And so if patients are symptomatic or someone I've known for a while and I know they have trouble and need to be monitored, we need to check their weight, right? I mean, it's a little hard to get a good vital sign assessment over the camera. Certainly the eyeball test is very important. So for patients who have been stable on their medication for some time, that would be someone who's very appropriate, I think, for a telemedicine visit. Okay. Sometimes patients have imaging, and the imaging doesn't look, you know, like we're accomplishing what we want. You know, it can be challenging to give bad news over a telemedicine visit and discuss next steps. So certainly I think patients are offered that. In reality, a lot of patients are more than happy to come in, especially if we think it's necessary.
Okay. And
Can I point out where there's actually a benefit to the telehealth here, which is the fact that we're doing it more. I found that there are people we're more willing to talk with on a weekly basis, whereas before they might go several weeks starting a new therapy, maybe having some toxicity. They might not contact us. We try to have our staff reach out to people. But now that it's more formalized, it's more recognized as part of the care, that insurers are reimbursing for this, I actually find it more comfortable to have more visits with some patients. And so I think some people that would have had symptoms that we wouldn't have picked up on as early, we're actually starting to pick on a little bit earlier. It's harder to examine somebody, of course, but at least you can hear how they're doing.
Mm-hmm. Great. Dr. Kim, what's your experience been with telemedicine?
Yeah, so I said our first patient was on May 13th. So we've been doing a telehealth for now almost 8 weeks now. And the overwhelming majority of our cancer center patients, now we are seeing them over telehealth. Again, our area has been heavily hit. So I have to say that there are limitations. I mean, just like Rich said, I mean, there are a lot of limitations. Can't examine them, can't touch them, can't see them. The video is not clear enough such that I can't sometimes see the eye colors or skin colors and so on. So lots of limitations. But at the same time, there have been a lot of benefits where a lot of our patients have been glad to see us over the phone, glad to talk to us, perhaps have a better access, per se, to our providers. And at the same time, particularly those patients who live far away from the medical centers, the access and or at least the telemedicine care has actually given a lot of benefits to those patients. So I think that especially with COVID-19 will be with us for several more months. I think telemedicine will probably be with us for some time, if not for a long time.
Okay. Dr. Salgio, and just to close up the topic, what's been your experience with telehealth?
Yeah, we also had to switch almost entirely to virtual visits, mostly by video. You know, I also have found that it's allowed me to see the patients, especially those on systemic therapy, more frequently, just keep a pulse on them a little bit more regularly. Of course, the exam part is limiting, but in all aspects, whether it's pre or post-transplant, the HCC care, and then a lot of our specialists involved in the care of these HCC patients have been using the similar format. So I definitely find it limiting from the standpoint of having those crucial conversations, showing the empathy that you want to or that you need from, you rely on having that in-person visit to do. But I think given the current circumstances, the patients have really appreciated being able to have this forum. We're hoping to shift back to more in-person visits as the month of May goes on, but I think we'll probably do some hybrid for at least foreseeable future.
Okay. So I just want to be respectful of time. There's a couple of things I wanted to talk about still before we start taking Q&A. So just to warm you guys up, I would like to talk about research and clinical trials, both enrolling and patients that you have actively engaged. I mean, what's the situation like? Who'd like to start that one off?
We have monitored that very closely. I mean, because there's staffing issues. Schools are closed. Maybe parents have to be home, the coordinators. But we have continued with research, but at a very closely monitored level, right? Regulating how many patients are screened in a given week, how many can be consented. And so far, that seems to have worked, and reacting to the load of the system. And it has not been overloaded on our end.
Okay. Additional experience?
Yeah.
We had to halt enrollment. Go ahead, Mike.
No, I was going to say we've definitely been limited. They put in place different tiers of studies, which ones could continue, which ones couldn't. Even the ones that can continue, somewhat limited. And some of it has to do with referrals. As referrals have decreased, we obviously don't have the patients who necessarily can go on studies. Some of the studies that have required, particularly investigator-initiated ones that require some lab input, the laboratories are by and large closed down right now, so it's difficult to continue some of those.
Okay.
Just for now, during the crisis, we are not enrolling new patients, new subjects, and we are not opening new trials just for now during the crisis. But as we try to normalize, we'll open back up.
Okay. Dr. Salgia, last words on research?
Yeah, our experience is the same. Any new starts are not being done, but patients who are already on treatment through a trial have been allowed to continue. But for all the inconsistencies of being able to provide the necessary care through this time, any new trials are not being started temporarily.
Very good. So last question for the group, and this is a two-parter. So one, long-term, after we get through this, is there anything specific that you think will impact the way you're providing care for patients with HCC, and any other advice for other providers? So we'll start with Dr. Finn.
Well, I think it's going to be very important that patients don't get lost in this shuffle, right? Patients who have put off follow-ups or appointments, that they follow through with that. And there needs to be a system to make sure those patients are scheduled or get called back in, because there's been so much chaos out there with the fear of this disease that it's paralyzed a lot of people. And I think as that resolves, hopefully sooner rather than later, we'll be able to get back to normal and get patients back into the flow. Telemedicine, I think, has gotten a foothold, and many patients, I think, are going to rely on that in the future as well as a way to access health care. And that's something we'll have to think about.
Okay. Dr. Morse.
Well, one concern we haven't really addressed, because I think people aren't sure what the full impact is going to be, of course, is the whole financial toxicity issue. How to be more efficient with the resources we have, especially as a number of people whose health insurance may be affected by their jobs or the jobs that they had, or family members whose health insurance they were depending on. Co-pays might be more challenging for people. It's clearly going to have to be dealt with, and I think it will help in some ways think about how to be more efficient about healthcare costs. But so far, I haven't really seen much changing in that regard. So hopefully there will be more emphasis put on that.
Okay. Dr. Salgia.
Similarly, I do worry a little bit about the financial implications for our patients. And, what we'll see as more time goes on, I think we will see screening for HCC, diagnostic testing, and treatment delayed, and the impact of that will probably be greater as more months transpire. But I think that there's also some things we're going to do smarter, whether it's the incorporation of the video visits to allow better access for patients and for as providers to be able to see our patients more frequently and chat with them, but also, just prioritizing patients and thinking about our algorithms and who we approach at what time with what particular intervention. So I think there will be some of our practices that come out looking better at the end, but it's going to take a lot of time and unfortunately a lot of heartbreak along the way.
Okay. And Dr. Kim?
Yeah, so I think, I personally think telemedicine, telehealth is here to stay, even for liver cancer patients. But likewise, and that might actually enhance the access to the providers. But likewise, cancer center, liver cancer group, or GI cancer group will probably need to be even more vigilant of following patients and the giving hands to patients so that no one gets left behind. But the one major concern that I do have, and we are seeing this actually in the cardiovascular and other service lines, but I'm just concerned that some patients might wait too late and show up to the hospital or ED in advanced stage or very sick. And I'm very concerned about those for patients with liver cancer.
Okay, very good. Thank you. All right, so we have some time for questions, and for our audience, if you'd like to submit them, open up the Q&A window. It will open up on the bottom of your screen, and then go ahead and send something over. So first question, and I think Dr. Salgia, you kind of mentioned this in your closing words, but about screening. So the question was, when might you expect, and I know we're on the virus's timeline, but before we start doing more active HCC screening?
Well, I think that's going to depend on the location where one practices, and everybody's recovering or seeing incidents and surges at different times. And with that, every health system is adapting differently. I think that, and ILCA had recently had a good webinar about this as well. But I think we're trying to avoid putting off HCC screening necessarily beyond a period of about 8 months between studies as much as possible. I think that's really what we're trying to emphasize. It may not be possible if patients lose their health insurance, but really trying to think of maybe a 1 or 2 month delay in ultrasound and AFP as potentially acceptable, but trying to get them within about that 8 month window. So that's what we're doing and emphasizing. And I think when it comes down to those conversations with the patient, as much as we have to balance it with their fears, they certainly don't want to have misdiagnoses of the HCCs. So that's, I think, the conversation we have to be having with them.
Okay. So a question, and I know this is still a topic that's ongoing in the news. What's screening like when you're having a patient come in? Are you actively testing for COVID?
Not an asymptomatic patient.
The answer was so good we heard it a few times.
So we have now started to test for COVID pre-procedurally. So in anybody who is coming in to get a procedure, an operation pre-transplant, the COVID testing has initiated with the nasopharyngeal swab. But otherwise, anybody coming in for routine labs or ultrasound, any other imaging is just getting temperature checks and question screening at the door. And then they have to wear a mask. Yeah.
So at Yale, all of the pre-operative or the older patients coming in for operations needs pre-testing within 24 hours, which could be relaxed to 48 hours soon. Also, many of the interventional cases, the patients coming in for such needs of pre-testing. In fact, as the testing capability goes up, I'm pretty sure that pretty much every single patient will be tested or required to be tested for such.
Okay. So, a question, and I certainly like to get a variety of responses from everyone. So, we've talked about how this has affected the way you treat and interact with patients. A question from one of the audience is, how is that affecting the way that you're working with the other professionals, the multidisciplinary teams within your institutions and practices? Dr. Mort, why don't we start you off?
Yeah, several ways. So, of course, and I'm sure this is the case for everybody, our multidisciplinary conference is now virtual. Everybody, radiologists, we're all dispersed. Yet it's going fairly well. And I think it's encouraging people who otherwise would have a harder time making the meeting to be able to join. The second area, though, is we've often performed, quote, multidisciplinary, is incorporated really as in the clinic. I sit in the same clinic as hepatic surgeons. We have ready access of radiation oncology in the building. Interventional radiology is often in clinic at the same time, maybe in an adjacent building. But now that we're even in the workrooms trying to distance ourselves, that has actually made that type of interaction more challenging. So we definitely have to make sure we're emailing or calling people on a much more regular basis if we're not able to kind of see and sit with them in the same room as much as we had before.
Okay. Dr. Salgia, what's it like in your neck of the woods?
Yeah, very similar. Our two virtual, one member of each discipline in live presence at the tumor board, but the rest are joining virtually. It's just requiring a lot more communication, certainly between individuals to make a decision. Other part I would emphasize that we've been trying to do is really also connecting with our referring doctors, because a lot of them, I think, are struggling with knowing who's open for caring for their patients, especially those who are around the state in areas that may not be as hard hit. And so we're trying to reach out more personally to them just to let them know that, where we are in terms of caring for these patients with HCC, what kind of services we're offering, and the shifting timeline.
Okay. Dr. Kim, how have you been interacting with other folks in your health system?
Yeah, so the good thing is all the care, all the work, all the multidisciplinary care, particularly HCC patients, they're all getting done. We are all here, we are all working for our patients. But the downside is all of these works are getting done virtually rather than in person. So there's a good and not so good, perhaps. I have to say personally, what I missed the most for the last 8 weeks is I can't shake hands with my patients. I haven't been doing that. I don't know if when it's the next time that's going to be allowed, or say the people will socially accept. But I feel bad.
Yeah.
I think that does mean something, but nevertheless, having to be sort of socially distant from my patients physically, that has been actually a big deal.
Yeah, we can't even do elbows. I mean, it's so we'll work on that. All right. Last word, Dr. Finn. Can you give us your perspective on working with your colleagues?
Yeah, it's continued pretty well. I mean, our tumor boards are a WebEx, and in reality, we don't need to see each other. We just look at the images and we talk. And so that has worked out pretty well. And echoing what other people said, sometimes people can't make it to tumor board. Sometimes they would call in, but now it's set up that you can call in and actually see the imaging. So I think, to echo what we just heard, I think the thing that's really missed is the personal interaction, not only with our patients, but with our colleagues. right? Medicine is a very collegial field, especially these multidisciplinary tumor boards and curbsiding, and hopefully this will all resolve very soon.
Yeah. And for all the folks that do work remotely, which I am one, I must say I've looked into more of my colleagues' homes than I care to say. I've seen basements, I've seen bedrooms, all sorts of things. So while it's not as personal, it's still personal. So with that, we are at time. I would like to thank our panel. It's been a wonderful conversation, very insightful. And again, I would like to thank Genentech for the support of this program and enabling us to come together this evening. On behalf of our faculty and OncLive, thank you everyone who joined this evening. And again, thank you, for all of the providers that are on our panel and all of you who are watching. Thank you for continuing to care for our patients. If you're looking for more information about the impact of COVID-19 on oncology, visit OncLive.com. And again, thank you everyone, and good night.
Good night.
Thanks.